Okay, great. So, good afternoon, everyone. My name is Mike Bernstein. I have the privilege to serve as the new practitioner chair of ACRO. Thank you so much for joining our monthly webinar series. It's about 12 o'clock Eastern Standard Time, and I know everyone is extremely busy, so it really means a lot to us for you to join. I'm so glad that you did, because we're in for a real treat today with Dr. Fumiko Chino leading our webinar. She and her work obviously really need no introduction, but today's webinar will focus on a frequently overlooked but often real devastating toxicity of cancer treatment, which is financial toxicity. She will highlight the high cost of therapy and how that can negatively impact patients, their quality of life, their access to quality care, and sometimes leading to an erosion or degradation of the type of cancer care that patients may receive. Um, Dr. Chino is an MD cancer researcher and assistant attending in the Department of Radiation Oncology. It's Memorial Sloan Kettering Cancer Center in New York. As you know, her research has focused on financial toxicity, healthcare disparities and access, patient-reported outcomes, shared decision-making, survivorship, and end of life. Her work has really been extremely well received and recognized nationally and internationally. I have the privilege of working with her and also calling her a friend. So without further ado, I'll leave it off to Dr. Chino. If you guys don't mind, please make sure that your microphones are muted throughout. We've disabled the chat function, but towards the end of the talk, when we're ready for the question and answer, please feel free to unmute yourself and ask any questions. So thank you so much again for everyone joining, and thank you, Dr. Chino, for your time and your upcoming talk.
Thank you so much for having me again. It's a pleasure to talk with you guys today about financial toxicity and cancer treatment in America. I have no disclosures. So financial toxicity is really a new name for a growing problem, as Dr. Yusuf Zafar, who was my primary mentor, actually said. And it's a term that is used very frequently, but sometimes used mistakenly. So when we think about financial toxicity, we're really thinking about how costs are affecting patients. And this ASCO opinion survey from 2018 actually features one of the core concerns that a lot of our patients have, specifically about the finances and access to care that patients are having. And the thing that I always like to highlight is that there was actually more people who were worried about the financial burden of their cancer diagnosis than they were of actually dying from cancer. So the concerns about the cost of care are really pervasive, unfortunately, in American society. This has trickled all the way up to, the New England Journal of Medicine. Dr. Ubel was also one of my colleagues at Duke, specifically wrote this about how we should be disclosing the costs of care as a potential side effect, just as you would talk about peripheral neuropathy or bone marrow suppression. This has trickled also to the lay public. So for example, USA Today wrote this piece a couple of years ago, specifically talking about how these costs are really affecting cancer patients directly, causing them to skip their medications, potentially even skip on their treatment altogether. And Forbes has actually been, in terms of the lay press, has actually been a real leader in terms of highlighting how the costs of cancer treatment have been rising and how this is actually affecting the quality of care that patients are receiving. And so this is when I really need to say that I unfortunately do have a disclosure, not that I make money from financial toxicity per se, but that I have given money from financial toxicity. And so I shared my own personal story on NPR a couple of years ago, specifically talking about how when my husband was diagnosed and when he was treated, we were suffering incredible costs, and we did not have conversations about those costs. And unfortunately, when he died, those costs really followed me. And ultimately, the financial toxicity that we suffered from his cancer treatment is one of the reasons why I'm a physician today. So I'm very passionate about this topic because unfortunately, I have experienced it personally. So what is financial toxicity? What is this phrase that is frequently used, potentially too frequently used sometimes, in terms of the new way that we consider costs and how it's affecting treatment. So the National Cancer Institute defines financial toxicity as the problems that a patient has related to the cost of their medical care. And they specifically highlight that patients with cancer are at a bigger risk of financial toxicity. In my own words in JAMA Oncology, in one of my commentary pieces, I said basically, even with health insurance, these high costs are really affecting some vulnerable American families, and it's leaving them in debt. And it's having effects on the quality of life and the quality of their health care that they're receiving. So we know that financial toxicity has effects on patients, but why does this matter? What is it actually affecting? So we know that it's decreasing the quality of life for our patients. We know that it's decreasing the satisfaction that they have with their cancer care, and we know that ultimately it's actually decreasing the quality of cancer care that they receive. This is what I like to call the unholy triangle, or the unholy trinity, in terms of decreased quality of life, because you can see that financial distress, perceived quality of care, and quality of life are all sort of interrelated, with advanced disease sitting in the middle. And we know that patients who have a lot of financial problems are much less likely to consider their quality of life as good. Clear direction, essentially, that multifactorial, but that financial distress is really contributing to a lot of quality of life issues. Whoops, let me go forward, sorry. We know that financial toxicity or costs are really decreasing the satisfaction that patients have with their health care. So this is a study that was published a couple of years ago in The Oncologist, where we specifically looked at how satisfied patients are with their cancer care. And you can see for patients who have low financial burden, their overall satisfaction scores are like just a standard bell curve. But that for patients who have high financial burden, everything is shifted towards the not satisfied end of the spectrum in terms of their satisfaction. And the actual scores, or the components of the satisfaction that was affected, were the general satisfaction, obviously the satisfaction with the financial aspects of their care, but also the satisfaction with the technical quality of their care. And a lot of these questions are really like trust questions. They're like, I trust that my doctor has the right diagnosis for me, or has the capacity for treating me. So all of those questions potentially can point to the maybe erosion of care that's being done when you have high costs. We know that there is a decreased quality of care when patients have high costs and financial toxicity. So for example, one of our studies looking specifically at medical adherence found that about 1 in 4 patients are actually somehow compromising the quality of their care related to their costs, including about 1 in 5 who just didn't even fill a prescription related to their costs. And I think terrifyingly, 1 in 20 who actually, compromise somehow the efficacy of their actual cancer treatment by not filling or taking less of their chemotherapy. We know that financial toxicity also increases things. So it decreases quality of life, satisfaction, quality of care, but we know that it increases things like, personal and family burden, the risk of bankruptcy, and ultimately, increases their overall mortality. This is a study published 2 years ago in JOP, specifically looking at what were patients actually sacrificing in order to afford their care. And we found that 2/3 of patients were making at least some sort of sacrifice, of which about half of them were having to use their savings. A quarter of them were actually borrowing money or going into debt. And about 1/3 of patients were actually spending less on basics like food or clothing. We know that financial toxicity doesn't affect everyone equally. And so there are specific patients who are at a bigger risk of a poor outcome in terms of financial toxicity. And this study out of the Michigan group specifically looked at financial toxicity and found that actually Black or Latino women with early stage breast cancer were actually more likely to lose their home related to the financial aspect of their treatment. And this is sort of terrifying because you're thinking about, well, this is a very treatable, very curable, disease, and we're actually making people homeless from the cost of their cancer care. So you can see that there's some populations that are really at a bigger risk. We know that there's an increased risk of bankruptcy related to a cancer diagnosis. And so this was the seminal Ramsey study that actually looked at essentially over almost 200,000 citizens, and then sort of assessed to see who had declared bankruptcy, who had a cancer diagnosis. And they found that essentially a cancer diagnosis was an independent risk factor for bankruptcy. You were basically 2.5 more times likely to declare bankruptcy in the context of a cancer diagnosis. And this really matters because, we have these rising costs, we have, decreased quality of care, quality of life, and then ultimately we know that there's an increased risk of death. So the follow-up study for Ramsey was to actually look to see for those patients who actually had declared bankruptcy in the context of a cancer diagnosis, what was their overall mortality. And he found that there was actually almost an 80% increased risk of death related to essentially this potential erosion of financial stability in the context of a cancer diagnosis. So again, our treatments are causing people to be homeless, and they're causing people to actually die related to the cost of their care. And I would say, for a moment, I'm at MSK. We're talking about potentially a pretty charmed patient population that we're serving, and we say, well, yeah, I know that's happening in the community, or that's happening in this area, but these are really, that's not happening to our patients. So I always give the example of essentially what is happening at MSK. So again, a charmed patient population, but we know that this is happening here. And when we actually looked, my colleague, Dr. Vicky, actually looked within our own system to say, well, within MSK, how many people are actually having problems? So we define a problem as having multiple bills sent to collections, being on a payment plan, having to declare bankruptcy, or utilizing a financial assistance program, things like that. And we found that 1/4 of our patients were actually experiencing financial toxicity as defined by those metrics. And we also found that essentially the majority of those concerns are based on payment issues. And about half of people were referred to assistance programs. I think terrifyingly, not everyone had been referred to an assistance program. And, we had patients essentially who were sent to collections that never actually received any financial help with that. And then, when we actually looked specifically to see when this was happening to patients, it was not like when patients walked in the door. Financial toxicity is something that develops over time. And so the patient that you see for your new consult may not be having problems at that time, but they may have it 6 months later, or for example, for us to ultimately send patients to collections, that took over a year in terms of kind of the maturation of financial toxicity. So I should say, it is a common problem, even in centers with, the highest level of care. So where do we go from here? Because, I described, unfortunately, a very sad situation for some of our patients. Not everyone, but some patients are very much suffering. So, how did we get here? We know that financial toxicity is really driven by many things. One of them is just rising healthcare costs. So there's basically no one, I think, on this chat who hasn't seen a graph like this, which is just a line that goes up. And we've had increased healthcare spending from $75 billion in the 1970s to over $3 trillion in this most recent, within the last decade. We know that the price per capita in terms of healthcare expenditure is rising. So from basically $350 per person in the 70s to over $10,000 per person as of 2016. And unfortunately, we know that the price of cancer drugs is rising. And sadly, it is not matched with a commensurate benefit in terms of the actual clinical actual benefit. So this was a study that came out a couple of years ago, specifically looking at each new anti-cancer therapy and its price, which is in the blue line, and then its actual clinical benefit score, which is calculated either by the ASCO or the ESMO framework. And you can see that essentially the benefit is stagnant, if not actually decreasing over time, even as these prices are rising. So we have, these higher drug pricing, higher healthcare costs, And increasingly, those costs are being kind of shoved off onto patients. So there's increased cost sharing for our patients. And this is reflected by, for example, if you look at just the median household income, which is essentially stagnant over time from the 70s, you can again see this rising price in terms of the actual anti-cancer drugs, the monthly prices. You can see there's a clear disconnect between essentially where are the, drug prices as a percentage of income is, being rapidly outpaced. We know that underinsurance is a big problem. So underinsurance is when you spend more than 10% of your take-home pay on your healthcare costs. And so this study from JAMA Oncology from 3 years ago specifically found that basically the median patient in our study was underinsured. We had a high portion of people, 1 in 6, who were having high or overwhelming financial distress. And those people who had, overwhelming distress were paying over sometimes a third of their income on healthcare related costs. And that sadly, these unexpected costs were really, decreasing their actual willingness to pay for care. So potentially pointing at how patients can start eroding the quality of their care by maybe skipping appointments or skipping medications if their burdens are too high. We know that there's increasing treatment. Just honestly, we're treating more people than we ever have in the United States for cancer. And a lot of that is actually like overdiagnosis, over-treatment. So we're routinely diagnosing and treating cancers that will probably never actually affect their morbidity or mortality for a lot of patients, including things like DCIS or low-risk prostate cancer. Sometimes I'm having to try to talk people out of radiation for some of their low-risk disease that probably will never, have a real problem with them. And we know that there's aggressive treatment at the end of life. So some of the things that are basically contributing to these high costs, including burdens on patients, is just the fact that we don't know when to quit. I mean, we have 3/4 of patients who are younger are receiving aggressive care in the last month of their life, including a third who die in the hospital. We have people who are older who are receiving ICU admissions at the end of their life, including over a third who had chemotherapy within the last 180 days of their life. One of our studies actually recently just found that about 1 in 6 patients actually had received extended fractionation for palliative bone metastasis within the last 6 months of their lives. So again, like we're potentially treating people aggressively at the end of their life, and it's unclear if it's actually giving them a significant benefit. We know that there's these rising costs. Increasingly, those costs are being pushed onto patients. We're just treating more patients. And then there's some good things. We have these clinical technological advances that are really potentially making a huge difference for our patients, but that also cost a lot of money. So one of them is just the fact that we're ordering more imaging studies than we ever have before. So imaging, use of CTs, MRIs grew 15% annually in the 2000s. It's still rising. It's just I liked that over 15% annually. And unfortunately, we're ordering some of these studies without real clear definitive evidence that they improve cancer staging, surveillance, or outcomes. I think there has been some really great studies about some of these imaging studies, but they're, we're really not thinking of it from a health policy or health cost lens. I have seen beautiful MRIs used for breast cancer. I'm not sure if they actually improve the outcomes for those patients, though. I think on an individual level, there's the potential, but on a systems-wide level, we're sort of routinely implementing some of these more expensive imaging studies without potential understanding how the costs are trickling down to patients. So again, PET CTs, MRIs, increasingly using without clear evidence. And just an example for that is, this is from a book chapter from the latest Gunnarsson and Tepper, specifically looking at MRI for liver cancer. And so you can see on the top is the CT scan and on the bottom is the MRI scan. And there's beautiful delineation of that tumor from the MRI scan. And even in this chapter, which I wrote, I say that it's vital for assessing vascularity, extent of tumor, diagnosis of liver cancer. But the actual clinical trial to show that MRI is better than CT scan for liver cancer is actually still accruing data, and it's actually not expected to be published for another couple of years. So am I confident that MRI is better for diagnosing and staging liver cancer? 100%. Is that actually backed up by significant high quality evidence? I would say no. So we may be getting ahead of the data for some of our imaging studies. Another thing that we may be getting ahead of the data of is some of our expensive new technologies. And so Forbes has estimated that new med tech is actually responsible for up to half of the annual cost increases within healthcare. And again, sometimes we're using these modalities without clear evidence that there's a cost-effective benefit or improved oncological outcome. So a lot of these obviously are radiation modalities. So for example, for IRMRT, there's been cost-effective analysis that it is cost-effective for prostate cancer, but that for example, gynecological cancers, which is also used, I'll be honest, quite commonly, the quality adjusted life year cost of it is well over $200,000. And again, the quality is a metric that is that tries to point essentially, tries to assign a dollar amount to what we consider to be a good quality year of life. And the threshold within the United States is typically considered about $100,000 for what's considered effective. So within our own field, we're not necessarily doing the high level of analysis and data to actually show that we're worth it, because our treatments cost money, and they may prevent late toxicities, but we should really probably show that. So where do we go from here? Because again, we have these high costs, it's causing effects on our patients. We're sort of spinning out of control in terms of the overall healthcare dollars that the United States is spending. Cancer is one of the huge contributors of that. So, I like to think of this in terms of kind of nesting frameworks of how we can consider interventions or ways of addressing financial toxicity, from policy to provider to patient. So systemic, interpersonal, individual. And I think, the largest aspect is just sort of policy. So how do we think about engaging all of these kind of key stakeholders, patients, healthcare systems, researcher society, and, provide some policy guidelines that can actually help steer us in the right direction. So the President's Cancer Panel is a group of stakeholders that meets every couple of years to provide recommendations for how we should steer the direction of future cancer research and priorities. And they specifically, met 2 years ago and talked about value and affordability, and had some recommendations on essentially how do we align drug prices with their value, how do we continue to guarantee affordable access, how do we continue to promote future innovation. So if you're looking for a easy read of 180 pages, I would suggest that you read the report to the President of the United States from the Cancer Panel. Some policy initiatives are kind of obvious. So the Affordable Care Act was a healthcare policy initiative. It was intended to improve access to care. And having health insurance does lower patient costs, as opposed to, again, paying completely out of pocket for something. Having health insurance can really help make treatment affordable and ultimately save lives. This is the Jamal study that was specifically looking at patients with a new cancer diagnosis and whether or not their insurance status changed. And I think not surprisingly, they found that patients who lived in Medicaid expansion states had a steep decrease in the rate of uninsurance at the time when they were diagnosed with their cancer, and that the biggest gains were specifically in patients who were low income. So essentially the people who are also at the biggest risk for financial toxicity related to their cancer treatment. We know this specifically actually worked. So this was a working paper out of Michigan, specifically looking at the level of decreased medical debt for patients who are allowed to get Medicaid expansion. And what you can see is essentially the amount of money they had in medical collections and patients who had cancer or a chronic illness actually had much less money in medical collections, or a decrease in the amount of medical collections that they had after they enrolled in Medicaid through Medicaid expansion. So it actually did work to decrease the amount of medical debt that these patients had. We know that on a sort of policy-wide area, price transparency is a huge potential solution. So, if we can make better choices about where we receive care, then maybe we can actually, save some money and still maintain high quality of care. The first initiative from the Trump administration was specifically to January 1st, 2019, was to require hospitals put out charge master lists. So this, although well-intended, I think was incredibly flawed. This analysis from JAM Oncology from earlier this year from the UNC group I really liked, because they basically said, you know what, these charge master lists are very hard to find, they're hard to interpret, they're not actually useful in terms of price transparency for patients, and there's an incredible variation of prices. The new way that the US government is going to try to improve, price transparency is set to actually go live the January 1st of next year. This will actually require hospitals to actually list their negotiated prices for care, which will potentially be way more useful for patients when they actually think about how to compare what Memorial Sloan Kettering is charging for SBRT prostate versus what NYU is charging for SBRT prostate. We know that one of the potential ways that we can actually improve financial toxicity for our patients is to do things like de-escalation research. So how can we provide the same level and quality of cancer care for our patients, but just save money? These are two studies that are specifically looking at, can we get by with less? Is less more? I actually really love the abiraterone study specifically because this is actually something the pharmaceutical company kind of knew already. They knew that actually low dose abiraterone with food was, so that if you took this drug with food, that it actually increased the amount of active drug within your body. And so they had been telling people don't have it without food. And we could potentially save a significant amount of money by actually using a lower dose and just telling people to eat it with breakfast with a fatty meal. The second is a study that actually came out in ESMO 2 years ago, specifically looking at how we could potentially use a lower dose of an immunotherapy, and that this would be actually less financially toxic for our patients. Another way, sort of health policy-wise or kind of systems level, is to think about how do we actually implement evidence-based hypofractionation. So if a treatment takes less time for our patients, they're more likely to be able to go back to work faster, or they'll use less of their vacation days, or they'll be less tenuous in terms of their household finances, and they will have less travel costs. So these are, 3 studies, 2 of them which just came out in the last, well, one of them just came out 3 days ago, looking at the Florence trial for accelerated APVI. So, we could potentially treat patients with early stage breast cancer in as little time as a week, when traditionally they may be treated in, 5 to 6 weeks. And we are saving them not only costs, but also time and travel. I put in the CHIP trial too, just again, specifically, if we're cutting down prostate cancer external beam treatment from, 8 to 9 weeks all the way down to 4 weeks, we really are potentially helping our patients go back to their normal life. And for patients who are still working, that lack of income is a huge black hole that really contributes to their financial toxicity. In terms of financial toxicity, we could also just do true comparative effectiveness research. On the top, we specifically, the minimally invasive surgery for cervical cancer was just explored specifically to find out this rapidly implemented technology that we were all very excited about in terms of cervical cancer appeared to actually be worse in terms of overall survival. And then on the bottom, of course, is, the holy grail is, can we actually prove that proton therapy is better for certain cancers in the patients where really, long-term outcomes in terms of their actual symptom burden and long-term toxicities from treatment. The higher costs may be 100% worth it if we can decrease rates of dysphagia or chronic pain. The last kind of healthcare initiative I'll talk about is just the Choosing Wisely campaign, which is cancer tests and treatments that are specifically performed without lack of evidence, and as they're an opportunity that we could improve the value of our healthcare that's delivered. And so ASTRO has now put out 10 of these, one of them just being, again, hypofractionation. If there's a compelling reason to use conventional fractionation, 100% go for it. But it should not be the default in terms of our decision making and how we deliver care. Same thing for the palliative bone metastasis. We should not be using extended fractionation schemes, which again, we showed in our analysis from earlier this year that it was actually still being used for people and at pretty high rates and even for people at the end of their life. I'm sorry, last thing in terms of healthcare policy is to think about how we are actually being reimbursed for our healthcare and how our fee-for-service model is actually a potential disincentivization for actually improving the value of healthcare for our patients. I actually really like in PRO, they just published something by Dr. Lee, which was sort of like a guide for what is the alternative payment model for radiation oncology, how these episode site-neutral payments potentially could save the healthcare system money, how it can save potentially our patients money, but then also what are the potential flaws of the APM in terms of radiation oncology. So I just spent, let's just say, the last 15 minutes talking about these kind of larger, Affordable Care Act, price transparency, payment models. But a lot of people actually want to know what they can actually do for the patient that's in front of them in clinic. So what at the provider or the patient level can we actually do to potentially improve financial toxicity for our patients? So I really like to think of this on sort of a public healthcare model, a public health model in terms of primary prevention, secondary prevention, and tertiary prevention. So how do we prevent disease before it ever occurs? How do we reduce the impact of a disease as soon as possible? How do we soften that impact ongoing so that it has less kind of chronic effects? So primary prevention, how do we prevent it from even happening? So some of this is patient level, some of it's provider level, and some of it is both. One of them is just education. So, hey, there's this problem, it's called financial toxicity. It means that sometimes costs are high and that's compromising care, and we just need to be aware of it. Because if we're not even aware that some patients are having problems with their costs, we're like never gonna ask about it. So education on both a patient level to say, hey, it's okay to talk about your costs. On provider level, like, hey, some patients are really suffering, that really matters. For patients, things like shared decision making. So maybe, if patients were actually aware of the true costs and benefits of their potential treatment, they would actually, even choose a potentially a cheaper treatment. So that's certainly been shown in, for example, orthopedics for knee replacements. There was an overall cost saving from just actually engaging patients in conversations about the procedures that they were about to undergo. Optimizing health insurance through, for example, financial navigators has actually been shown to not just save patients money, but also healthcare systems money in terms of unreimbursed charity care. And then at the patient level, just continuing to improve their access. So for example, figuring out a way to actually arrange their treatment around their work so that they can continue to have some income coming in, so they can actually continue to have their health insurance through their work. Part of the COVID pandemic that has been really devastating for some of our patients is that they all, a lot of them have employer-based health insurance. And if they lose their job, they lose that health insurance, and that puts their cancer treatment in incredible danger. At the provider level, again, education, but thinking about value-based care. So the ASCO value framework, I'll touch on briefly, but how do we really think about aligning the treatments that we're recommending, their benefits, but also their costs? Things like early adoption of evidence-based hypofractionation. If we can get patients done sooner, that's more convenient for them, but it also saves them money. And then just cost-aware prescribing patterns. So thinking about how the drugs that we're actually prescribing do have costs for our patients. And there's some drugs that are more expensive than others. I was shocked when I found out that Anusol was going to be $400 for my patient. So thinking about education, there was actually the first study specifically looking at randomized financial counseling for patients, which actually provided an estimation of patient out-of-pocket costs, the definitions and the sort of details of their specific insurance, and then who to contact if they're having problems. And this study found that the vast majority of patients actually found that this meeting with a financial counselor really did help them actually understand their costs better, and potentially anticipate those costs a little better. So financial counseling could potentially help in terms of a preventative measure. Some of it is just knowing how much things cost. So this is Partner is a study that is still, unfortunately, taking a little longer than I thought, enrolling at Duke, but we're trying to actually categorize the costs that patients have when they're receiving radiation treatment for head and neck cancer. And to actually, say, what the range of costs for patients was, from $10 to $10,000, because right now we actually have really no idea how much patients are paying for their radiation. Part of this component of the study was actually also to include educational materials to see if patients found them helpful, if giving them some information upfront about their side effects, including financial toxicity, could actually help them understand their costs better or anticipate their costs better. As I mentioned, the value-based framework is specifically ASCO, which, as you know, is the American Society of Clinical Oncology, put together a guideline to facilitate conversations with providers and patients about specifically value. And this is one of the examples that they give, which is, I'll be honest, the most obvious example that they could have about, for example, if you have two treatments that have the same overall survival benefit, they have the same toxicity in terms of for patients, but one of them costs significantly more, then you should just pick the cheaper treatment. And then this kind of skew is basically if you have a certain patient population where there is a bigger benefit, well, then that would make up for the costs, and that is when that treatment really becomes more worth it, essentially. So secondary prevention, which is essentially how do we reduce the impact by detecting it early? So how do we diagnose financial toxicity? The simplest way is just yes, no questions. So are you having problems related to your costs? So this is the NCCN problem list, which is a yes, no check mark list of about 30 problems that most NCCN centers give to their patients. And they can fill it out in the waiting room. And there is one question, which is a pretty good screening question for if patients are having problems with the insurance or their finances. But there is actually a more detailed or specific diagnostic tool for financial toxicity called the cost score. And this is 11 questions. It takes about 5 minutes to complete. It's scored on a Likert scale. And this has been validated in cancer patients specifically to assess their level of financial toxicity and its effect on quality of life. These questions are very straightforward. They're, I feel financially stressed, or I feel in control of my financial situation, or, I have enough money to actually cover the cost of my treatment. So pretty straightforward questions. And these screening, either the yes, no problem or, cost should be done at multiple points if there's if we're interested in financial toxicity, because of how financial toxicity can develop over time. So diagnosing it kind of when it first happens would be important in terms of actually preventing some downstream effects. Tertiary prevention, again, how do we, once someone actually has financial toxicity, how do we really soften the impact of that, how it can affect them? And I think this one is kind of a straightforward solution, which is we should probably just be talking to our patients about their costs. We should probably just be asking them if they're having problems. Because I know personally from my own experience, we never talked to our physician about our costs, and they were excruciating, and they were requiring significant personal sacrifices for myself and my husband. We really know that talking about money is not easy, and it's really honestly makes both patients and physicians uncomfortable. But unfortunately, if we're kind of, if it's uncomfortable to the point where it never comes up, we're potentially missing something really important for our patients. So I think the first thing is just to, open the conversation and to say, hey, are you having any problems with affording your care? And I think, what we know based on the evidence is that most patients actually do want to talk to their doctor about their costs, but sadly, only 1 in 5 have actually talked to their physician related to their cancer costs. And sadly, less than a third have talked to anyone within healthcare about their costs. So not to the check-in person, not to the financial care counselor, not to a social worker. And some of this may be because they're not having problems with their costs. But as my recent study about parking costs just showed, we're really thinking about, in terms of really thinking about how costs are affecting patients, there are many levels of how patients are actually having to make sacrifices in order to afford their care. The reason why cost conversations matter is that we know that they actually can work. They don't work for every single person. They don't eliminate costs down to zero. It may be a small fraction of their costs that get lowered, but we know that over half of people who actually discuss their costs actually found that those costs were reduced. So in the study, we found that the majority of these costs were reduced without actually changing any cancer treatment or cancer plan. It didn't compromise their care. And most of them were just essentially referred to the appropriate financial assistance. So again, patients who don't want to come into the city to receive their brachytherapy related to parking costs. I would never know that unless I actually asked why they didn't want to get their brachytherapy. And we have philanthropic support for things as stupid as parking costs. So just me figuring out what the barrier was in terms of costs can actually help us identify solutions for patients. Sometimes, again, it's just appealing directly to insurance, or even switching medications, switching from Zofran to Compazine, changing the frequency of tests. So if NCCN says I can follow someone up between 2 and 4 months, then maybe it should be 4 months and not 2 months, if there's really no benefit to following them closer. Thankfully, we know that cost conversations don't have to take long, because none of us have an extra 4 seconds in our template for forever long conversations. The median cost conversation duration was actually less than a minute on this study that looked at over 600 patient interactions. They found similarly that only about a fifth of patients actually had a cost conversation. Most of them actually were physician initiated in terms of the conversations that were had. So again, on the provider-patient level, there's, really multiple ways that we can potentially intervene, from, preventing financial toxicity from forming through education, through, value-based care, from diagnosing it early so that we can, kind of intervene earlier, to, tertiary prevention. How do we normalize these cost conversations? How do we actually refer appropriately to care? I think the last thing I always want to say is just, what we're spending is a lot of time on the bottom of the pyramid for people who are already having problems. And we really need to think about, how do we really flip the pyramid? How do we invest more time and effort into prevention and less into actual treatment of financial toxicity? So how do we really help people from the get-go, as opposed to trying to dig them out of a hole when they're already in the hole? So I'll leave it with just thinking, mitigating financial toxicity is possible, but unfortunately we know that it's really growing in the United States, and it really matters because cancer outcomes are at risk. So I have just talked for 45 minutes. I am a fast talker. So I appreciate y'all's patience with me. I'm happy to answer any questions while I suck down some water.
Great. Thank you so much, Famiko. That was really a wonderful, spectacular talk on such a vital, timely topic that sometimes unfortunately gets overlooked, but can, as you mentioned, really impact our patients. So as we had said earlier, sorry, we did disable the chat function here, but if you do have questions, feel free to unmute yourself and ask. I also see that there's a raise hand function. If you click on the participants, maybe you could raise your hand, and then once I call your name, maybe that'll be easier for us to just hear one person at a time. So it looks like Linda Jokanovich.
Hi there. Yeah.
Thanks.
Hi, I'm Linda Jokanovich from Cancer Legal Care in Minnesota, and I really want to thank you for this fabulous presentation. One thing I'd like to offer as a solution at the patient and provider level is to bring in lawyers to help, because nearly every social determinant of health is tied to a legal intervention. And one way in Minnesota at Cancer Legal Care that we're helping to address cancer's financial toxicity is to help our clients stay employed by knowing employment rights and employment laws that are there to protect them, to help with foreclosure prevention, do insurance coverage appeals, things like that. So I would just make a comment that there is a wider group of professionals who can help address these issues as well. And thanks again for such a really great conversation this morning.
No, I think that is a really important additional aspect to think about is how do we rally a multidisciplinary team? And I think, classically in healthcare, where like multidisciplinary means like the pharmacist and the nurse and the physician. But truly, how do we involve all of the support avenues for patients, from social work to even lawyers if they need it? I think that you make a really good point, which is sometimes we're so tunnel visioned about healthcare that we don't really think about. There are many aspects of how costs are affecting patients that you can't really focus on actually getting to your radiation appointment if your house is being foreclosed, or if your employer has fired you illegally for a protected health condition. So I think that's a really good point, which is we need to be rallying resources for our patients. And a lot of the community healthcare delivery cancer centers are really leading in this in terms of like thinking outside the box and what our patients need.
Right, and I would just add, if people are interested in learning more about this, there's the National Center for Medical Legal Partnership that's based out of George Washington. And then there's also a group of us that Legal Health in New York City coordinates called the National Center for, the National Cancer Legal Service Network. And there are a few of us around the country that focus on this work. So thanks again.
I think that because of the COVID pandemic, and because of so many people now losing their jobs, potentially their health insurance, but also potentially losing their homes, that's going to become an increasingly important issue in the next probably year, if not more.
Great question, great answer. Next up is Carmen. You can unmute yourself.
Thank you. Yes. Hi, Dr. Chino. Thank you so much for the fabulous talk. I've been reading about your work for a long time and trying to put my head around this problem as well. And it was so useful for me to hear it for the first time from you personally. So thank you for all of the insight. One of my several colleagues here at the University of Pennsylvania have worked on a new framework of behavioral economics and choice architecture. And I wonder what you think of approaching this problem, perhaps by making some of the suggestions you mentioned as the default option. So if there is a drug, for example, that's just as good, but it's generic, why couldn't that be the default, that the doctor has the ability to write, but override if there's a really good reason? Why couldn't we make the default that every patient sees a financial navigator unless they opt out of this? And so I'm wondering what you think of that approach and whether that has any legs. Do you think if it has merit whether there's an ability to pursue this going forward, and maybe invite you to collaborate with us. Thank you.
No, I really do think that in terms of behavioral economics, it's like the 401k, whether you opt in or you opt out, there's a significant benefit for the whatever the default action is. And they've actually found that, for example, for providers for disincentivizing like low value services, that if they just change the default within the EMR, they actually can increase adherence to higher value care. And so I do think that there's a real potential benefit for just building high value care and patient focused interventions into baking it into how we deliver cancer care. I had actually specifically looking at a trial of just, again, meeting with a financial counselor from the outset as a default, because it really only happens at this point within cancer care. If you're having a problem, you say, oh, can I talk to the financial counselor? And then you get referred. And the main resistance that I found was just the staff. And so the institution needs to make it a priority to hire the additional people to actually make that make that a default. And so, for example, within MSK, one of the things that, one of the programs that we have developed over the last 2 years that I obviously only became involved with the last 1 year, I can't say it was my idea, was this idea of this enhanced copay assistance team. So like a Navy SEALs crack team of patient financial services that's specifically focused on patients who have the highest needs, which are patients who are prescribed a new oral anti-cancer therapy or a new IV cancer therapy that has a known high copay. And so for that service within MSK, what we've developed is that those patients are not they don't have to request to be referred. They don't have to go to the pharmacy, try to fill that medication. It's $7,000. Oh my God. They actually get referred kind of behind the scenes as soon as the prescription is put in, so that the patient financial services people can be working on that automatically. And one of the things that we're trying to do is to have essentially as part of the intake paperwork at MSK, someone to essentially give us permission in addition to being able to request their health records from your prior treatment team or their pathology slides, but give us permission to actually start the process for financial assistance behind the scenes should it be needed in the future. So I actually really love that idea of the default should be providing all services for our patients. It just, again, demands that institutional commitment.
Thank you.
Great, thanks. How about we'll go to Daniel Hayes. You can unmute yourself.
Hi, can you hear me okay?
Yep, we can, perfect.
Hey, Dr. Chino, this is Dan Hayes. I'm on the local chapter of American Cancer Society here in Philadelphia with Carmen, who invited me to this, so thanks for the time. I had a different question, but being an accountant by background, I would say if you want to get your institution to back that financial counseling idea, just show the payback of when you counsel somebody and how much they pay you back. It should justify the cost pretty easily. My question, I had two questions, one around price transparency and the other about underinsured. And I was curious, if you're completely uninsured, I get you're underinsured, but if you're not, how would you know that, as a physician? Because generally if somebody's working, the only plan they have is what's offered by their employer or Medicare. And then secondly, on price transparency, which would go into that discussion, I remember I was on a local hospital board and there was discussion about this. And I was always confused. Well, what are you going to talk to me about? Because when I get a bill from the hospital, it says standard charge $10,000, allowed charge $1,200, you pay $30. So, which one am I supposed to make the decision on? Because 30 is easier than 12,000. So just kind of curious, your thoughts on that.
Yeah, I think one of the real, I'll be honest, one thing I'm very proud of the Trump administration is pushing forward this idea that hospitals need to start publishing their negotiated prices, because the negotiated prices are negotiated at the level of the health insurance plan. And so you could potentially compare within your own plan what the negotiated price was for example, chemotherapy. So unfortunately, again, drawing from my own experience, I know that my husband was treated at MD Anderson and at the University of Michigan. And when at the point at which he transferred care, he was receiving the same 2 chemotherapy drugs. And the actual billable charge was almost 5 times greater at MD Anderson. The negotiated charge was obviously lower, but sadly for us, because we were essentially in, I'm going to call it the donut hole, even though we didn't have Medicare. Since we were in the all out of pocket for MD Anderson, our default was then essentially the entire billable charge. So the negotiated rates is really what you should be, making decisions on, and that's what is currently not transparent, but hopefully will be in 2021. The other question that you had, I apologize, I've already forgotten.
Sorry, I talked too much. It was underinsured. How would you know that?
Yeah.
Unless they're completely uninsured.
Yeah, so sure. So ironically or not ironically, people that are actually completely uninsured potentially have an easier go of it because all of their care is then charity care. So they know that they have limitations in terms of who they can receive treatment at. But for those, their incapacity to pay means that essentially all of those bills are then wiped away because most hospital systems have some amount of charity care. For the underinsured, because they do have health insurance, sometimes they're actually in a worser bit. And so what we have tried to do, again, just speaking of my work here at MSK, is to actually identify, so for our study, looking at the 90,000 people who received active treatment in the last 3 years, those 25%, 27% who actually had financial problems, how do we actually reverse engineer, because everyone at MSK has health insurance, how do we reverse engineer the aspects of them that we could potentially anticipate when they were going to get into problems before they actually got into problems. So that, because all of those patients, once you get into the point in which you have bills sent to collections, were clearly underinsured, right? So their burden of their health care was too great compared to their income. So I agree, it's a really tricky topic at the provider level to really think, well, who is the person who's potentially at risk? And that's why my baseline advice is just to say, you know what, open the conversation now. The vast majority of your patients probably won't need that avenue, but it's a real lifeline to people if you can just start from the get-go and say, hey, cancer care is expensive for some people. Depends on your insurance. If you're ever having a problem affording your care, I want to hear about it. Because after having one too many patients hospitalized in a pain crisis with 20 pounds of weight loss because they couldn't afford their OxyContin, I know that patients aren't necessarily going to tell you that they didn't fill that prescription. They're just not going to fill it.
Great. Wonderful questions and discussion. I know we're just at the 1 o'clock hour here on the East Coast. Maybe just, I have one quick question for you,
Sure.
Fumiko, if you don't mind, and then we'll kind of wrap up. What is your quick thoughts on the oligometastatic setting and field? Because as we can see, a lot of it is moving towards that direction, and we know in non-small cell lung cancer it's been proven, but it's now been extrapolated to other disease sites, like you had brought up about breast cancer patients, prostate cancer patients. And so how are we and a lot of the treatments for metastatic disease is the fancy SBRT. So how are you reconciling that literature with your important data that you've shown? Thanks.
Yeah, that is such a good question. I have to say that I had a real shift when I transitioned to MSK, because we are, frankly, we'll SBRT anything. And so there's an institutional mindset that really flavors how providers really think about the treatments that they recommend. And I think the way of really trying to combat the group think is to really try to set guidelines either at a national level or institutional level in terms of what is considered to be high value care, what is considered to be low value care. There are still times when 100% an outlier to that, there's a great reason to deliver that treatment, go forth. But we should have these potential checks to think about, well, for someone with widely metastatic disease, why are we doing SBRT for this specific lesion off trial? Because what are we really trying to get? And I think some of that for us can happen at chart rounds, which is, like, what was the decision-making process that led to you recommending this treatment? And is it truly what's best for patients? But I will 100% admit that I prescribe SBRT way more than I thought I was ever going to, just because of the potential internal pressure of having that be the standard of care here. So I guess the solution may be to try to change the standard of care within each institution to have a groundswell, or potentially, nobody likes a top-down mandate, but to think about how are we really trying to improve value for our patients and not just zap it.
Yeah.
It's
That's
hard.
great.
I mean, I'm sure you've ran into this as well.
Yeah, absolutely. Those cases are certainly challenging, but I think your approach sounds perfect. Well, just to be respectful of everyone's time at 1 o'clock, unfortunately, we'll have to end this really wonderful discussion and engaging conversation. Just wanted to thank everyone for joining, and also a sincere thank you to my friend, Dr. Chino. She did such a wonderful job on such an incredible topic, and really brings light to this important issue that we should all be having this conversation with our patients. And it just sounds like the first step is just open lines of communication. Just let patients know that we're here for them, and if they need us, we'll support them any way possible. As the chair of the new practitioner committee of ACRO, I really appreciate everyone coming. Please keep your eyes open on your emails for upcoming webinar series. We usually do them once a month. So please register when you see them come through. We'll do a lot of these other fantastic talks like the one that we just had. Please go to the ACRO website. There's a lot of interesting topics going on. Keep your eye out for the annual meeting. We have mentorship programs, seed grants, membership, interest in people that want to become active in the field, leadership opportunities, networking. So, ACRO is a really wonderful college to join and an organization. And as you can see, we bring in real leaders in the field for all of our talks. So appreciate everyone joining, and thanks again for your time. Hope to see you next month. Thanks, everyone.
Thanks for having me.